In this segment, we're going to begin HVLA to the lumbar spine. So we're going to start with a very common technique, the lateral recumbent high velocity, low amplitude to the lumbars. Similar to the muscle energy technique of the lumbars, the rotational component of the dysfunction determines the side on which the patient lies. So in this case, our patient is lying on the right side. The patient has a right rotation component to his dysfunction. So this dysfunction we're going to make, we'll say that we diagnosed an L5 type 1 neutral side bent left rotated right dysfunction. Patient's lying on the right to go with that right rotational component. Now, I find the L5-S1 interspace, flex the hips up and down until I feel that L5-S1 open and close, separate and approximate, and find the midline neutral between that range of motion. In this case, I'm pretty close to a 90-degree angle. It depends from patient to patient. Type 1, I'm going to take this leg off the table and just drop it in front of the other leg and go back and never lose this segment here so I know what I have. Now, some people like to take the patient's arm here and pull them around for the rotation. However, if you do that too early, the top part of the trunk and shoulder will actually rotate back and the patient will be lying on the table and then you can't really do anything. So I like the patients to stay more perpendicular of the trunk to the table. And then what I do is I start by finding the segment here, side bend to my right barrier, and then rotate the patient over first and then see what happens with the shoulder. And in this case, the shoulder doesn't come back too far because I've already started with my side bending and rotation down from this lower portion down here, get that to the barrier in the other direction, and then work top down. So here with our side bending left, I side bend it right, rotation right, I rotate it left, and now I just keep feeling to make sure I'm right at that segment. I tend to lean down on the patient, rest a little bit of body weight on my forearm, and I can roll my body back and forth to the side bending as I keep that rotation, and then back and forth, rock my body back and forth for the rotation until I get that edge of that barrier. When I was in school, we were taught to get a very hard edge restriction. I tend to believe now it's a little better to stay more with that feather edge barrier we talk about with muscle energy. And I have it here, and basically now I have, if I wanted to use some soft tissue techniques, muscle energy techniques, other things to see if I could get it before I had to do HVLA, I could do other things, but in this situation, let's say we're just going to do HVLA for an articular dysfunction, L5 neutral side bent left rotated right. I have the patient take a deep breath and exhale, and I just make sure that I stay with that barrier correctly, all the components are there. I might leave the rotation maybe a little freer or the side bending so I don't have it too locked up to keep the patient more comfortable, as this is a direct technique. If I block it up too much, you might feel some pain. So I try to keep it comfortable, feel that there's no guarding, the patient's allowing me to do this, take another deep breath, and he lets it out, and then my two hands just move like so in the direction of the rotational and side bending barriers. So I bring this hand towards me and down, this hand back and up cephalad. Now, if you want to, you can, with a little more experience, if you did that little thrust and didn't feel anything happen, sometimes the patient recoils a little bit, and before they start tightening up again, you can actually put the spring right back in. And sometimes you can take a technique where you might have an 80% percentile of success and bring it up to a 95%, but that takes a little bit of experience. So that was an L5 neutral, side bent left, rotated right, HVLA.